What this study basically looked at is the complex question of when to transplant and what type of transplant to do. The cohort in this study was very well defined. We found 20 patients who received an autologous stem cell transplant and 20 patients who had received an allogeneic stem cell transplant. There were no patients that had transformed follicular lymphoma in this analysis. The patient characteristics demonstrated that the allogeneic stem cell transplant was slightly older and they had slightly more therapy. Now, when we talk about the outcomes of this study, we really looked at many factors, but what fell out and was clinically interesting to us was the concept of remission duration. As in all of our patients in the allogeneic stem cell transplant group had a remission duration less than 12 months in the chemotherapy that preceded their induction therapy with the intent to consolidate with a some form of a stem cell transplant. And from there we found that when you look at the autologous stem cell rescue cohort of 20 patients, we had a nice separation in those who had a remission-free duration of less than 12 months did worse than those who had a remission duration greater than 12 months to their pre-induction chemotherapy. In the allogeneic stem cell group, again, as stated, all 20 patients did not had a remission duration less than 12 months. So when we go and we compare those patients who had a remission duration less than 12 months and went on to have an autologous stem cell transplant to those 20 patients who had less than 12-month response duration with an allogeneic stem cell transplant, the 3-year event-free survival is statistically significant in favor of an allogeneic stem cell transplant. I think that this is a building block or a first evidence to say maybe we should be looking at remission durations in modern chemotherapy regimens, and then asking ourselves the question, if transplant-related mortality and graft versus host disease is limiting the utility of allogeneic stem cell transplant, maybe the next step is clinical trials looking at to see if we can reduce the transplant-related mortality, which is most often related to graft versus host disease in the reduced intensity transplant regimens that we are using currently.